Hi. Thank you for the invitation to participate today. I've really enjoyed being part of the day here so far. I'm a researcher embedded within Kaiser Permanente Northern California's Division of Research. So I will be able to share sort of, the organizers asked me to share a little bit about the way I see the evidence for sort of two modalities of telehealth, and I agree wholeheartedly that the modalities of telehealth are very broad, but specifically patient-physician secure messaging and then patient-physician video visits with the patient at home, essentially, rather than from a clinic. I'll share a little bit about sort of how I see the evidence and then a little bit about things that we've found in our setting. So I guess I'll skip through this really quickly. I agree that the primary benefits as we see them for patients right now for both patient-provider email and video are essentially access and engagement. The statistic that was quoted earlier, I think, is the sort of key operational one to think about. This 2-hour burden for the patient to see their provider can, in some cases, not all at all is not the approach we're going at, but can in some cases be sort of offset through telehealth. And we see impacts on improving engagement also. So another sort of reflection I have before we dig into the literature is a little bit, as I was contrasting these two modalities, I was realizing that patient-physician email through a secure messaging service like in a portal really has come an enormous distance in implementation just through meaningful use incentives. And that was an interesting contrast to really there are lots of flaws to probably that model, but it's amazing when you think about sort of adoption that has been pushed there, sort of from it being a rare thing probably less than 10 years ago, whereas video visits are really increasing due to basically consumer demand, absent a clear sort of policy incentive. It's consumer and employer demand that sort of seem to be pushing that forward, and therefore many of the experiences outside of these integrated systems are these third-party services really trying to meet that consumer demand without necessarily having integration with an in-person healthcare system. So quickly on patient-provider email, and I think the research literature there is that there are still plenty of gaps to fill, but is much more developed because adoption is much farther along. We see typically that patients who email their provider get more or better preventive care and chronic conditions care, things like that. Some of that might be because some of the patients that are more engaged are using secure messaging with their provider, but a lot of it is probably because the secure messaging is really engaging patients and helping them to further their self-care and care seeking. There's really still a fairly sort of complex interaction between patient-physician secure messaging and in-person visits. It's kind of the question that's always on the table, and I think the evidence is fairly mixed there. Probably some of that having done sort of a PCORI-funded study where we talk with patients often are able to tell stories about ways that they intentionally, because it was more accessible to them, avoided an in-person visit, say. And then other patients say they, might have gone in even hoping to avoid an in-person visit, but find themselves, the provider says, hey, we should probably this is concerning enough, we should probably have you in for some follow-up care. And therefore, there are these kind of countervailing trends, I think, that create a lot of sort of complexity in the research evidence there. But I think the gaps are still in the digital divide, which it remains. Language and other kind of communication barriers are still difficult to overcome in patient-provider email systems as they stand now. Caregivers and family care partners really use these things fairly often, but there isn't a whole lot of research evidence out there about it. And then, as has been mentioned a couple times today, sort of the store and forward model of patient-physician secure messaging, I think, is while implementation, I think, has progressed fairly well, there's really pretty limited research evidence as I see it there. So this is just a slide that we found in a survey of patients using the portal in our system. Just to give an idea, this is patients who use the portal to email their doctor with their primary care provider. And what we see here is just that patients are using it as their first method of contact across a whole broad set of concerns that might come up in primary care, most often here for medical test results, but also for new medications and new health conditions and ongoing conditions and referrals to specialists. It's really like a broad set of clinical interactions that are happening by secure message. We also asked them, because health outcomes are challenging to get at, and those are things that we are trying to study directly, one of the easiest ways to get at it is by self-report. So we asked patients, did it improve your health? And a third of people say it did. 2/3 said they couldn't, tell a large measurable impact on their overall health. And thankfully, hardly anyone said it made their health worse. In terms of that question of sort of impact on in-person and telephone care, we also asked patients to sort of tell us about their experience there. And about 1/3 of people said it decreased their office visits, being able to secure message with their provider. And 40% said it might have offset phone contact, so we might even see sort of greater benefit there. This is a paper that we published just last month. It's a research letter in JAMA Internal Medicine where we looked through that PCORI-funded study at caregiver experiences using the portal, which we found to be fairly common. At the top there's sort of this intergenerational effect where the primary use case was for a spouse or partner, but people are also using it for children and grandchildren, and then up towards the, maybe parents or grandparents who are aging. And overwhelmingly, we find that people report that it's a convenient way of participating in their family members' care, that it's faster than other ways of participating in their care. And that's sort of again, a use case that I think is not very well described in the literature. On the issue of digital divide, which we're always looking at and trying to do our part, essentially, to overcome. We see, and there's lots of papers on this, a broad range of rates of use across sociodemographic characteristics. And one cool thing that we've done is to think about, the barriers to that. A lot of them are, device and internet access. And when we account statistically for having internet access and device access, essentially, we see a lot of those kind of dampen. So we have some reason to be hopeful that as sort of technology proliferates, maybe that will help us to handle some of the digital divide issues. I'm going to switch here now to video visits, which are kind of a little bit sort of the hotter part of telehealth that people often think of. I'd say here the evidence I agree very much with what others have said, that essentially there's a ton of evidence on very targeted specialty use cases, especially rural and specialty access. The evidence is actually really, really strong. There are a whole bunch of RCTs where people have implemented a specific program, whether to bring the patient into clinic and telehealth out to a specialist or to do it at home, where they've been shown effective. There are a lot of these smaller efficacy studies. I think where the gaps might be is in sort of broader use cases. And there are a couple of studies on this sort of more third-party consumer-initiated telemedicine visit where the patient contacts a third-party service that is not linked to their existing provider. I think that those are widely in demand, like we heard the employer group perspective represented earlier, widely in demand, and people are widely satisfied with them. I think the evidence is a little bit uncertain there also about whether or not it might offset in-person care, and the quality impacts are really uncertain. There's sort of mixed evidence there too. So basically, the evidence gaps in telehealth are really wide. It's basically everything else besides ruralty and specialty care. There's little out there on primary care, new, ongoing, urgent follow-up issues in primary care, little out there about integration with ongoing healthcare and providers. I think it's definitely happened, as we've heard today, but we haven't really been able to get that stuff out in the evidence yet. More broadly, the quality impacts and the health outcomes, the signals are positive, but the real ability to demonstrate those scientifically is still catching up, I think. And along those lines, like I've mentioned, sort of the impact on in-person care, I think as a researcher, we think a lot about sort of the causal relationship between those things and how to capture them. It's just a very tricky thing scientifically to demonstrate, because when a patient wakes up, like the patient example today, wakes up in the morning with a health concern and wants to reach out through telehealth, we don't have any prior measure of sort of wrist pain before you contact the health system. And there are a lot of ways, I don't want to get bogged down in it statistically, to accidentally attribute that wrist pain to the telehealth visit, because our measure of it is the telehealth visit, rather than knowing that, it was addressing a prior healthcare need. So hopefully that's clear. I like to talk about these things. Happy to more. This one. Okay, so I'm going to share also some preliminary findings. We don't have these out there yet, but they're close, where we looked at patient-physician video visits in Kaiser Permanente, Northern California, where essentially they have rolled out video visit capability, patient-physician video visit capability to all clinicians. Everybody can do it across specialties. And we looked at sort of early adoption, both very descriptively, sort of general adoption statistics, and then what we did was actually pursue patient surveys, like I've showed you before, on primary care video visit patients in the last quarter of 2015. So I'll show you sort of both the large-scale automated data and then a little bit about what the patients tell us about their experience. You'll see the blue chart just shows that essentially adoption was increasing rapidly in that first year. Uptake happened broadly across specialties. This one has a lot of stuff on it. I think the take-home is basically that the video visits appear to be feasible across a variety of patient characteristics, ages and gender and race, ethnicity, and even SES. That doesn't mean that the adoption is equal, but just that it looks like these things can be done by a lot of different kinds of people. What we looked at in the bottom couple rows there is we were curious if these are primarily patients who had not been engaging in regular health care, whether these are people who, access barriers had kept them sort of away from the health system. And what we find is actually the opposite, that 96% of them had had an in-person visit in the prior year. 3/4 of them had had some kind of in-person communication in the prior 30 days. So these are really, in our setting with sort of this integration, these are really sort of ongoing care for ongoing health care ongoing health conditions. And then what we found interestingly is nearly 6 out of 10 of them were having a video visit with a provider that they already had seen in person. So these are sort of known and ongoing patient-physician relationships, which I think is unique given the integrated model. We've lost our titles. We just looked descriptively at the length of these visits, what was happening, and whether patients were doing them from a mobile device or, you could do it through a webcam also attached to your computer. We found the majority of them were actually done by mobile phone, a few by tablet, and then a third from a desktop computer. Interestingly, sort of the length of the visit sort of tracks with the mobileness of the device they used. So the mobile phone ones were about 7.7 minutes, and the desktop ones were about 10.5 minutes. Kind of interesting to see how the patient sort of, what devices they used. We asked patients about their reasons for having the visit. 82% said my provider can see me and better understand and treat my health condition. I think that reflects the patient experience that was shared earlier. Similarly, over 80% said it helps me miss less work, school, or other activities. That seems to be one of the most compelling sort of selling points to the patients, is that they can avoid transport issues, some people need others to take them to a visit or don't have transportation available. There are sort of caregiving responsibilities and childcare that need to be arranged, and some of those are basically non-starters for patients. So this offers an opportunity to skip over some of those hurdles. The bottom question there is kind of an interesting one. Almost half of patients said I'm more comfortable asking my provider sensitive questions, which was kind of an interesting and provocative finding on our part, but might speak to sort of some of the complexity of, in some situations, this sort of technology offering enough connection and also maybe some distance to raise things that you might not have been interested in or willing to raise during an in-person visit. We also asked them about their experience. Not over 90, and which was overwhelmingly positive, actually. 92% said the provider was familiar with my medical history and care from other providers. Again, this is in this integrated setting where the EHR is fully shared and it's documented in the same way as an in-person visit. 90% said they're confident in the quality of care delivered through their video visit. Down at the bottom there, we asked that same question of whether having a video visit decreased their in-person visits. And by self-report, interestingly, it's in about the same range. About 1/3 of people said it offset potentially an in-person visit for the same condition. So that gives us a little bit of signal of what we might find in larger studies. Of course, video visits, like I've mentioned, are not designed in our minds at all to replace all in-person care. And it was actually reassuring to see that even among patients who had completed a primary care video visit, 40% of them still said, in general, I prefer to get care in person, that this was not sort of, in their mind, a complete substitution of any sort with in-person care, but sort of as needed, probably service when it's convenient. Some minor portions of the study population were still concerned about sort of preparing themselves for the video visit and how to set up, their space. And some 11% still said that they're concerned about privacy of medical information. I think those issues might always persist. So overall, we find that a diverse set of patients can pull these things off, that nearly all of them had recent in-person care, which was actually kind of remarkable in our minds. And thereby, the video visit was often with a provider they already knew. This was sort of an extension of in-person, say, care that had been already ongoing. We found that video visits were successful and convenient. These are like 10 minutes or less, kind of convenient things that we can picture people fitting into their day, that they were high quality, they addressed their health needs, that providers were familiar with their history and the patient did perceive that. And then there is that sort of about a third who self-report that they had fewer visits for the same condition due to being able to handle whatever the health concern is through a video visit. So these are sort of early findings. We're still continuing to look at these, especially using even larger data sets, even though I think this is, one of the biggest out there in the literature, to look, especially I have an NIDDK-funded study right now to look at the impacts of patient-facing technology in patients with diabetes. So we're looking both at video visits and other types of portal and mobile app use. And then I'm very interested in also transitioning to look at patient-initiated telemedicine choice, like how patients make a decision, say with a given health concern between the different modalities that are available to them. Describing that more, I think, is important. Great. Thank you.